Thank you, Sue, for that lovely introduction. I'm going to do the first few slides and then Trixie's going to do some, if that's okay. So I just wanted us to go back really to talk about the evidence and reminding ourselves what it is about continuity of carer that makes a difference to outcomes for women and their families. So there's been a few Cochrane reviews over the time, and with so much evidence, it's hard not to say that it is actually making a difference. So if we start with the midwifery-led care Cochrane review, which was by Sandel in 2013, it showed there was a reduction in epidural, episiotomy, in instrumental birth, and there was also a trend towards a cost-saving effect for midwife-led continuity of care compared to other models of care. And then in 2015, midwife-led continuity models versus other models of care for childbearing women showed that women who received midwife-led continuity models of care were less likely to experience intervention, more likely to be satisfied with their care. And they found that it was at least comparable with adverse outcomes for women or their infants when women who received other models of care. Then another Cochrane review, midwife-led continuity models versus other models of care by Sandel in 2016, again showed that women who received midwife continuity models were less likely to experience intervention, more likely to be satisfied with their care, at least comparable adverse outcomes for women or their infants with other models, fewer preterm births, fewer fetal deaths less than 24 weeks, and fewer overall fetal loss and neonatal death. And the continuity of care Cochrane review by Hodnett in 2020 said that women who had continuity of care by a team of midwives were more likely to discuss antenatal and postnatal concerns, attend prenatal classes, give birth without painkillers, and feel well prepared and supported during labour, and also feel prepared for childcare. And resuscitation was less frequently required for their babies as well. And then we have interventions during childbirth to prevent preterm birth, which was an overview of Cochrane systematic reviews, which was by Medley et al. In 2018, and showed that there was clear evidence of reducing perinatal risk of preterm birth from midwife-led models of care for all pregnant women, so women of all risk status. So what are the most effective interventions during pregnancy for preventing stillbirth? This was a Cochrane review done by De Silva Lopez et al. In 2020. And that showed that where midwives were the primary healthcare provider, particularly for low-risk pregnant women, loss of the fetus or infant death fell by 16%. So we can't really fail to ignore so much evidence. And Sheila Kitzinger, God bless her soul, I'm sure a lot of you knew Sheila. And she did so much for childbirth. She wasn't a midwife, but she was a service user, and her voice echoed all around maternity and midwifery services. And in Sheila's Kitzinger Symposium in 2015, which looked at relationships, it found that women are 24% less likely to experience preterm birth, 19% less likely to lose their baby before 24 weeks gestation, 16% less likely to lose their baby at any gestation. And women were also more satisfied with the information and advice that they receive, the place where they give birth, their preparation for labour, their choice of pain relief, and their overall experience. And startup costs associated with introducing a new model of care, the results showed there were shorter hospital stays, fewer tests and interventions, so that it didn't cost any more than the current services that were being run at the time, as well as leading to improved job satisfaction for midwives. The key to implementing it and making sure it works was good leadership, allowing grassroots development of local models which address local needs, with supportive supervision and realistic planning underpinned by positive multidisciplinary collaboration. And I think those things are really key, as we found as we move forward. The Select Committee Safe Maternity Report was published on the 6th of July, and within it was done sort of like a CQC style of report, but it was done to review safety maternity services in England following concerning reports from Morecambe Bay, Shrewsbury and Telford, and some initial findings from East Kent. And it included looking at continuity of carer within that. And there was lots of evidence submitted to the Healthcare Committee in relation to continuity of carer, but they looked at a variety of evidence, and the overwhelming evidence was that continuity of carer does make a difference, and it makes a difference to outcomes and safety. And therefore it is supported by the committee to continue with the rollout of continuity of carer. They felt that it still needs improvement, requires improvement because it should be rolled out for all. Felt the commitment was inadequate, the funding resource required improvement, the impact requires improvement, but they felt it was appropriate and they rated it as good for that. And then also, Sue touched on it a bit earlier, is that our maternity services currently are under extreme pressure. And there's so many things to consider, and I listed everything that maternity services need to consider at the moment at this point in time, as well as dealing with the pandemic. And as you can see, the list is absolutely massive, and our leadership teams within maternity services need all of the support, as well as the midwives, maternity support workers on the ground caring for women and their families. And we mustn't forget that as we move towards doing transformation. So I'm going to hand over to Trixie at this point. Thank you.
Thanks, everybody. And thanks, Tracey, for setting the scene and just reminding us. Oh, can you go back to the last slide? So we have been through the most horrendous time, as we all know, yet I personally am really encouraged to listen to Nat and hear about how she's been getting on with her team, and actually how her team evolved and how it's working in a way that you'd expect it to do. So I would say well done, Nat and Jasmine team down there in Medway. It's just fantastic to listen to you talk. It's really good, and actually we need you to be multiplying. Now you might say, with all these problems, where are we at in the country? But let me encourage you, for all the crisis and all the difficulties we've been through, there is almost 100,000 women in a continuity of carer team through their pregnancy as we speak. So the last survey was done in March, and we're going to repeat it shortly. But we can tell you that there are more teams in place than there was last March, 371 versus 347. And that is despite the fact that many trusts who had set up teams but not following the guidance that we'd asked them to follow, you know, very big teams or not providing all three elements of care, different things like that, then had recanted from previous audits and said, no, okay, we realise we haven't done it right. But even so, all these new teams have come into play, 371 of them, caring for almost 100,000 women. And what's even more exciting is that these teams are being placed in the areas where women need it the most. So we've got 263 teams in areas of deprivation. That means the bottom decile, you know, the poorest areas in England. And we've also got 246 teams in areas where there are high populations of Black, Asian and mixed ethnicity people. So the people that most need this intervention, because they're the people that suffer the most adverse outcomes, are the ones that are getting continuity. So I think we should be really, really encouraged. The graph on the other side just tells us that the majority of team trusts are running at about 10%, but there are a few that are up to 50% and going on beyond that. Next slide, Tracey. So we do have some examples of excellent practice around the country. York was somewhere we went just well, I didn't go, I was online, but Tracey went last week to where they're doing absolutely brilliantly. I think they've got 47% continuity. Likewise, Barnsley doing really, really well. And then there's some places here that I wanted to mention because they've used our modelling tools. They've tested them out. So County Durham and Darlington, I think, have now got 5 teams in place, or about to, which is about 25 to 30% of their women. They've used all the modelling tools to check it out for us to see if it's going to work. And what happened in that context was the midwives were not keen on continuity when they started. But as those teams have rolled out, and word of mouth has got out that the midwives are having a fantastic time and the women are having fantastic outcomes. Things like women with a high smoking rate are now dropping their smoking rates. Breastfeeding rates that were really low are going up. So really fantastic long-term health implications for what those midwives are doing for those people's lives. So we see that those places are really making a difference. Milton Keynes, the informatic that you can see in the middle, the thing I wanted to mention about them was that they looked at their sick rates for their midwives, and they had a 52% reduction in sickness after joining a case loading team. So joining a team, just like Jasmine, just like Nat is doing, has reduced the sickness because people have enjoyed coming to work. They've enjoyed being autonomous. They've enjoyed being empowered, and they've got a consistent and manageable workload. So we all know when we go to work on that labour ward in any trust in this country, we don't know who's going to turn up. We don't know what our workload is going to be. But because when we reorganise our work, we can feel that we're in control of what we're doing because we know that we've got a 27 woman live caseload, and therefore we know roughly what our workload is going to look like at any given time, although there is a bit of variation as Natalie described to us. Next slide, please, Tracey. So what we're looking for is how do we get from where we are now, which is a sixth of women, to moving forward? And that's, you know, what we wanted to mention. So the Parliament, the government is behind this initiative. It's not going away, and we need to just embrace it and think of ways of doing it in the best possible way. Now, this part on the one side, the blue slide of the slide, just tells you what's been put in place by the government so far and how much money has been given, because trusts haven't been left alone. There has been a lot of implementation money made available, including that £96 million for additional midwives. And what we've also done on the other side is we've looked at how do we go from planning to achieving success. There is a certain list of things that you need to put in place, and we want to help you with this. And what I say at any meeting that I speak at is, if your trust or if you need anybody to help you with any element of this, do not be a stranger, and please just get in touch, and we would love to help you. Next slide, Tracey. So we've got some priorities, and actually the guidance that we've all been waiting for a very long time is just about through. It's just got to go through so many hoops and so many approvals, including Amanda Pritchard's office, before it comes out to the public. But what it is essentially wanting you to do, there's some formal things written on this slide, but what it essentially is asking trusts to do is come up with their plan and describe how they're going to get from whatever they've got. So in Natalie's example, she's got 1 team at her trust at the moment. She'll need probably about 19 or 20 to achieve default continuity of care. So trusts need to describe how they're going to get there and how they're going to go from the current usage of midwives in a traditional model to moving them across into a continuity model. Next slide, please, Tracey. So what we've put in place to help you is the NHSEI Toolkit, and there's spreadsheets, an example, standard operating policies, information about pay, information about training. There's even a mock board paper for people to take and fill in, so they've got something to send to the board. And essentially what it helps you do is see how doable this is. So in the toolkit, there is an example of how you do it. And generally speaking, if you've got your traditional birth rate plus that tells you where your midwives are allocated and how many midwives you need, you just translate that across into the NHSEI toolkit, and you should be able to redeploy your midwives without requiring extra midwives. There is the odd trust that needs 1 or 2 more for whatever reason, but generally speaking, using that traditional activity and acuity ratio modelling that Birth Rate Plus does for a traditional model, You just bring that across, and you ought to be able to deliver continuity of care in your trust with that. Next slide, please, Tracey. So there are, as we've said, certain things that need to be in place. And actually, what I've seen is we can all be learning from each other. So we listen to Nat and her experience. We very strongly say don't go for a shifted system, and it's exactly what Natalie experienced. You end up getting penned in, and what we want to do is give people freedom. You still know when you're going to do your birth availability, so you know when your out of hours work is going to occur. You still know when you're on holiday, so you can still plan all your time, but we can learn from the things that haven't worked well to share them with each other, to work out how we can do all of this better. And in doing that, next slide, please, Tracey. If we do it in the way that the guidance suggests, and if we use all these tools, we can avoid all these unintended consequences. If we want to make sure midwives in the right place at the right time, we just use the toolkit, and it describes where all the women are, where all the midwives are. Are our ratios still safe? Yes, they are. So we're safe to proceed, and it's just really easy to manage. There's never any double running. You don't need a whole swathe of extra midwives. It avoids unsafe and inconsistent staffing if you do it properly. It prevents being tired and being burnt out because you now have unpredicted and manageable workload. And the beauty, and Nat was describing this as a testimony to this, is actually when you set your teams up well and you prepare your teams before you start, you avoid the poor team working and the lack of communication that we saw at places like Shrewsbury and Telford, because the teams are built in an appropriate fashion, and therefore the teams work well. And this has been borne out by all the research that Michael West has done over the many years. So nobody's been asked to do a big bang, because we know that would be bonkers. We're asking trusts to do a phased approach. We're asking trusts to do it in tandem with recruitment, so you get your right midwives in place before you start doing too much. And then but at the same time, we do want to avoid a two-tier system. So everybody says, and I've had this said to me so many times, oh, the women get a better time, the midwives get a better time, it's not fair for the ones not in a team. So the answer to that question is, let's get everybody in a team except for the ones that want to stay in the core, and therefore everybody's happy. So hopefully that gives you a flavour of where we are and where we want to get to. And I will give Tracey the last word with the last slide. Please, Tracey.
Thank you. I just love this picture so much. It just epitomises everything. And, you know, we want women and their families to have the best outcomes, and we want our services to be safe. So staffing women and not buildings is the way that we need to move forwards. And hopefully we can help to do that as we move forwards. We know it's not easy. It's a whole system change, and it'll take time, and it needs to be done in the right way, and it needs to be done safely as well. So we need to ensure that it's phased and developed as we move forwards. But at the end of the day, it's about women and their experiences and their families, and also about midwives' lives and about work-life balance, and about midwives and support workers as well wanting to come to work and do their job and love doing their job as well. So that's where we'd like to be. So thank you.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.